Welcome, ladies and gentlemen, to another edition of Health Reform 2.0. This is our HealthyBytes series. HealthyBytes are our quick points for fast learners. They're to be shorter in duration, to cover topics at a general level and give you an idea of what we think's going on. And if you're interested in more information, then we'll be doing longer shows that will feed into it. As is normal, I am joined by my co-host, Tim Henning, and I'm going to turn to Tim and say, what are we talking about today, Tim?
Hey, thanks, Tom. Hope you're doing well. So today we're going to talk about why your pharmacist can't tell you that a $20 prescription could cost you only $8. So Tom, when I first learned of the pharmacist gag clauses, I couldn't believe what I was seeing and reading. And I was actually heard it over the television for the first time, so I went into this research. These gag clauses prohibit pharmacists from telling customers that they could save money by paying cash for prescription drugs rather than using their health insurance. Did my research, and much to my chagrin, what I learned is so startling, wrong, deceitful, and dishonest that I wanted to inform our listeners of this scam driven by the drug benefit managers. So Tom, what is a drug benefit manager? Sure sounds to me that's a group benefiting themselves.
Well, in many cases they are, but not always in the way you may think. The driving force of profitability in PBMs is predominantly rebates. There's some other ways PBMs, pharmacy benefit management people, make money. If they're administering programs for the states and the Fed, they get paid certain fees to manage and administer it. But by and large, PBMs and distributors provide from a low profit margin to loss on the base transaction. They're not really making a lot of money on the drug that's being sold. They're making their money on fill fees, management fees, and a number of other things, including if you're a PBM that's actually managing the flow of the drug itself. Now, the company I used to work for, we didn't manage the flow of the drug, but some do under 340B programs and others like that. You don't, if you're not managing the drug itself, you're not getting in the rebate game. But by and large, PBMs get rebates for the resale of drugs. The more drugs they sell, the higher rebate level they get. Selling or reselling drugs as a pharmacy or a distributor or PBM, again, is a low profit to loss business. The money that's made through the program fees and rebates and the sales of the prescription benefit cards, which almost all of them offer, is where they're really starting to build the profit back in the drug business. Drug companies provide rebates to the distributors, and distributors provide rebates, and the states and the feds get rebates, and there are many, many levels in this rebate game. And if the real prices ever got exposed, this would all go away.
Yeah. When we talk about pharmacists, we talk about them a lot in our Health Reform podcast and just how valuable they are. I'm actually headed to Mexico in a few days, and I'll be definitely visiting a pharmacist, which will stock up on everything I need and tell me exactly how it works and what I should be doing, and I'll pay for fraction for what I pay here. We've talked about that before.
Right.
So when I talk to the pharmacists here, I can't tell you how frustrated these gals and guys are when it comes, that they are unable to give this information to their customers, who many may be struggling just to pay their copays.
That's right. Well, pharmacists, Tim, are mostly employees. They're really nothing but cogs in the wheel. They do most of the time understand how this works, but often even the pharmacist doesn't know all the details. They know the operation of the pharmacy, but they don't always understand how the distribution game in pharmaceuticals work or how the big pharma companies work. Many of them aren't even aware of the mandatory federal drug rebates, which is continuing to drive the price of pharmaceuticals up. They believe, like the rest of us, that the pharmacy companies are just charging higher and higher prices to gouge the public. It's not that they don't increase prices to make more margin, they do, but that isn't the dominant cost of the problem that we have in this thing. Any other services that cost pharmacies money, they don't really want to do them. Pharmacists get paid to count and pour. that's what they get paid. If you work for CVS, if you work for Rite Aid, you get paid to count and pour. That's it. PBMs often pay pharmacies a fill fee for the counting and pouring, and this is where some of the profit comes from. The fill fees are in part derived from the mandatory rebates upstream in the distribution chain, or from the extra funding of the program that the PBM is filling under. So PBMs themselves can get a percentage of profit driven by how much they lower the cost of a program or lower the interaction cost with a patient. When I'm talking about programs, most programs are offered through federal or state government or municipal government programs, and there's a lot of them out there, like AIDS Drug Assistance Program. It's just really overall, it's just a mess, and it's a big part of why we have this quagmire. It needs to change, and it's why we advocate for this single point of administration that's going to fully coordinate not only all care, but all benefits as well.
Yeah, I think we probably should do a segment of an episode on this whole rebate thing, because most people don't understand it. And I did talk to my neighbor who just retired as a pharmacist, and they didn't really understand it either. So you hear about it on the news, but I don't think anybody really explained exactly what it is.
Well, Secretary Azar, Tim, the other day started to talk about rebates, but they're not talking about the federal mandated rebates. They're talking about going after rebates in the drug distribution chain. And I think they ought to be eliminated across the board. If we want fair and transparent pricing, rebates have to go, because they make us sell a $40 drug and it gets reimbursed at $5 or $10. And while the public thinks it's a $40 pill, the reality is the person's getting paid $5 to $10. Pharmacy companies, the manufacturers, are making $5 to $10 on that drug when they sell it. It is a completely false economic structure, and as a result, you can't figure anything out.
Yeah, we'll put that on one of our episodes and go into detail. So the good news is, I guess, is there's new pending laws in North Carolina, Georgia, and North Dakota to ban these gag clauses. But the lobby from the drug benefit companies, the Pharmaceutical Management Association, has filed suit in federal court to block the North Dakota law, saying it imposes onerous new restrictions on pharmacy benefit manager. Specifically, it says the North Dakota law could require the disclosure of proprietary trade secrets, including information on how prices are set. Sounds to me like the days of the good old patent medicine man are still with us today.
Well, they are. And keep in mind that you've got the drug companies that really don't care if they're disclosed, the manufacturers. But the distributors like McKesson and Bergen and Cardinal Health, they never want this disclosed, because if the rebates go away, the money they're making is going to go away. Even though they're not making a lot of money on rebates today, those three companies are making most of their money providing software to the pharmacies that manage inventory and help them figure out what they got to do with the drugs. But you've also got the states that don't want this to go away. The Pharmaceutical Management Association is really looking out for the interest of the industry in total, and it's less about the drug company. And it is really something that needs to go away. We need to eliminate and ban rebates entire in this issue. People think, oh, well, the rebate, it's lowering my cost for the drug. It's not. It's increasing your cost every year. What's actually being paid is the net, and it's the same all the time. We just put in a false number on top of it, and we use that false number as a pad to try and figure out how we squeeze additional margin. So we need to get rid of rebates, whether they're federal, state, local, distributor. We need to ban rebates in healthcare.
Yeah, we sure do. So thanks everyone for listening. Stay tuned for our next longer podcast, which will be entitled something to the effect of the predatory and hostile healthcare economic environment. Stay tuned for that. Should be really good.
See you later.
Thank you.